Yes, I'm Danny. I'm a physio at Great Ormond Street Hospital currently. Before that, I worked at King's College Hospital and worked in some of the neuro rehab beds there. And then, for the past 5 years, I've been a specialist physiotherapist in neuro-oncology. So as Jane said, this presentation is about a report, a review that Success has commissioned, looking at rehabilitation, neurorehabilitation for young people living with or beyond the diagnosis of a brain tumour. Last year, if any of you were here, you'll have heard me speak about why we wanted to do this, the importance of rehabilitation. But I think that point has probably been made now, so I'm not going to labour that point, and anyone who's had a conversation with Helen for lasting more than 2 minutes will know about the importance of rehab for children with brain tumours. So the reason why we did this was all of that background, but we as clinicians were hearing, so we recognise the importance of rehab, there's an increasing awareness of it, but we as clinicians were often hearing that there isn't enough. The experience of rehab from young people, from parents, wasn't sufficient. So really what we needed to do was, okay, we're hearing this anecdotally, but we need something to show us that this is actually the case in a sort of more data-driven kind of format. So that's what this was about. So the aim of the project was to conduct a retrospective review of rehabilitation of patients who have been diagnosed with a childhood brain tumour. And then within that aim, we wanted to review access to provision of rehabilitation services. We wanted to seek the views of parents and carers on the provision of rehab. And we also wanted to seek the views of the therapists who were providing the rehab. So there were three main sort of sources of data for this project. So the first was a clinical notes audit, which involved looking at letters, clinical notes, referrals, etc., looking at 15 different components of things that were pertinent to rehabilitation. So, for instance, what is this young person accessing physiotherapy? Are they seeing clinical psychology? Do they have an educational healthcare plan, etc., we also had a parent guardian questionnaire, so seeking the views of parents and carers about rehab. And then we also had a professionals questionnaire, similarly getting their perspective. So the patient population was drawn from two distinct time points of children and young people who received their brain tumour diagnosis at Great Ormond Street. The first population was termed time point 2, and these would receive their brain tumour diagnosis between 1 and 2.5 years from the start of the project. So you can see there that this was between June 2021 and January 2023. And then the second group was time point 1, and they were diagnosed between 6 and 7.5 years from the start of the project. The reason why we looked at two different cohorts was because what we wanted to do was examine whether or not the provision of rehab, the experience of rehab, differed for these two groups. In terms of inclusion and exclusion criteria, so the child or young person had to have a brain tumour diagnosis, and important to point out that this is both malignant and non-malignant brain tumours. They had to receive their diagnosis in those timeframes that I mentioned on the previous slide, and their primary treatment centre either is or was Great Ormond Street or our shared primary treatment centre colleagues at University College London. Exclusion criteria, so patients were excluded if they didn't live and therefore access rehab services in the North Thames region. I excluded patients with a palliative or very poor prognosis. Want to make the point on this that is not in any way to say that children with guarded prognoses or palliative prognoses aren't entitled to therapeutic intervention. They very much are, but this was just a decision made about kind of the not wanting to cause any moral distress for anyone answering questions about rehabilitation where their medical status may not sort of allow for that to happen. And then patients with primary spinal cord tumours were also excluded. The treatment for these differs somewhat from brain tumours, and also there is an established spinal cord injury network in existence already, whereas with brain tumours there is not. So the results. From the notes audit, you might be able to see there, but this is just comparing. So for time point 1, which was the children and young people diagnosed sort of 6 and 7.5 years ago, there were 43 patients identified, and then for time point 2 there were 58, so those diagnosed more recently. I won't go through each of these points, but just to say that if you kind of broadly look across the two groups, in terms of their diagnosis, the locations of their tumours, their primary care teams, and the treatment that they received, they were fairly comparable, although no statistical analysis was carried out. Just looking across the two groups, you can kind of see that they are broadly similar. So one of the things that we looked at the notes audit was access to community paediatrician, who's seeing a community paediatrician, a physio, an OT, speech and language, and clinical psychology. And I just looked at it from different perspectives, and this particular, looking at this perspective highlights that those who were primarily followed up by oncology were more likely to be seeing a community paediatrician, more likely to be seeing physio, OT, speech and language, and psychology than those who were primarily being followed up by neurosurgery. And then just looking at the data another way, so looking at children who received different types of treatment, essentially children who received chemotherapy, radiotherapy, and neurosurgical debulking were also broadly more likely to be seeing these sort of rehab professionals than those who had received a single treatment modality in isolation. Sticking with the notes audit, so the graph on the left, this is looking at what services children are currently accessing. So time point 2, as a reminder, is the more current cohort, and time point 1 is the initial sort of earlier diagnoses. So what we can see here, what the graph shows, is that those who received their diagnosis more recently are more likely to be currently accessing physiotherapy, occupational therapy, speech and language therapy, and psychology across the board. And then the graph on the right is just showing that children who received their diagnosis further in the past, so time point 1, were more likely to have an EHCP is an educational healthcare plan. So children in time point 1 were more likely to have an educational healthcare plan than those in time point 2. So other key results from the notes audit. I mentioned there were 15 parameters in this notes audit that I was looking at. In only 3 of the 101 patients that were identified for inclusion were all 15 parameters able to be obtained from me looking through the clinical notes, essentially. There was missing data in the other 98. The most frequent parameter that was unclear was school attendance rate, so whether they were full-time, part-time, however that might be, if the child had an educational healthcare plan, and if the child was accessing clinical psychology. So then just moving on to the professional survey, we had 66 professionals complete the survey. In terms of response rate, it wasn't able to calculate a response rate because this went out to various different services, hospitals, community centres, rehab centres across the network. So I don't know how many people this reached, but we had 66 complete responses from professionals, and you can see the breakdown of the professionals that responded there. One of the things that came out from this was I asked the question, how confident are you in signposting children and young people and their families to additional resources, charities, organisations, services that can support rehab? What we can see here, if I just tap on the next one, so there's the individual breakdown of each profession, but when you combine these sort of 4 professions here in terms of their confidence in signposting, what it shows is that almost 50% returned a negative response, so they were not confident to some degree in signposting young people, their families, to additional resources, charities, etc., of which there are a host. Success being one. But there's the brain tumour charity, there are cyclists fighting cancer, there are a whole host. So there was an underconfidence in signposting. And then another bit part from the professional survey was that asking children, does the area that you work has a specific pathway for children with acquired brain injury or for children with brain tumours? And what this shows is that 67% definitely didn't have any pathway for children with brain tumours. 9% were unsure, so only a quarter of services had dedicated pathways for brain tumours, slightly more for acquired brain injury. The final bit from the professional survey, and this is a little bit complicated, this one, but I'll just talk through a couple of the key ones. So we asked professionals to rank what was the biggest barriers to providing rehabilitation. The medical professionals and probably parents and young people in the room as well won't be surprised to know that the clinical capacity and constraints was the biggest barrier. But one thing I really wanted to highlight was about the personal knowledge of brain tumours and oncology. So PTC, meaning primary treatment centre, so those professionals who see more children and young people with brain tumours, their knowledge, their sort of, it was the least significant barrier for them in terms of providing rehab. But for the community professionals, this jumped to the third biggest priority. So this potentially points to a educational need, a training need for those professionals in the community that they feel underconfident providing rehab for young people with brain tumours. Moving on. So the parents and carers survey now. This all will look familiar because it's also looking at access to rehab services that they're currently accessing, and this mirrors the graph that I showed earlier in the notes audit, which is just to say that more people who are diagnosed more recently are seeing rehab professionals than those diagnosed further away, and I'll talk about that in a moment, why that might be. We asked for parents, which setting do you view as having provided the majority of your child's rehabilitation? And I'll just focus on the top sort of group of bars here for all the professionals combined. And what this shows is that it was the primary treatment centres that parents identified as providing the majority of rehabilitation, which, bearing in mind that may only be that first initial acute period, is just worth noting. I did a thematic analysis, and these were just some of the responses that came out of that. Both parents and professionals, the most common thing for parents was difficulty accessing services. Themes that spanned the two was a lack of coordination and depreciation in therapy services. Oh, I've just skipped one there. I also asked about kind of, have you seen particular services? Taking occupational therapy as an example, if the parent had or the child had not accessed occupational therapy, they were asked a follow-up question as to why that might be. 50% of parents actually indicated that they were either never offered or were unable to, and tried to access occupational therapy, feel their child would have benefited but were unable to do so. And this was a very similar case for clinical psychology, where it was 54%. I also asked parents to rank what are the most important factors relating to rehabilitation, from the most to the least. And what you can see here is that the parents, on average, scored that specialist knowledge and experience of practitioners providing the rehabilitation was the most important thing. And then you can see the kind of the hierarchy there of those kind of factors. Needs careful consideration of interpreting this, because that's not to say that some of these lower factors aren't important to parents, but it's just which are the most important. And then the big take-home message, the big kind of figure at the end was 51, so less than half of parents feel that the current state of rehabilitation services are sufficient for their children. There are some quotes here, but I'm going to skip past them just in the interest of time. And then this is just the kind of the main discussion points. So signposting was an issue, parental awareness of services, lack of dedicated pathways, clinical consultations and documentations. Are we, as clinicians, recording things correctly? Are we asking the right questions? There's access to rehabilitation is an issue, so occupational therapy and clinical psychology, particularly difficult to access. There's a potential depreciation in therapy input, so children are seen early on in their journey, and then that lessens over time. Few children are accessing dedicated rehabilitation services, so this wasn't on the graphs there, but only 7% of patients access a dedicated rehabilitation bed. There is an absence of cognitive rehabilitation, so 1 in the 45 children access cognitive rehab. So there is an absence there, but there is a desire for more, for sure. clinical capacity is a bit of an issue, and there's more training need for both therapists and parents. And I'll conclude there.